happening. And the probe I select is a curvilinear 2 to 9. So I'm going to start with. And then I do a sweep. The cervix up to the fundus. And I'm going to go straight to a cardiac examination because the baby's in a good position. And that's a good rule of thumb, is to, if the heart's in a good position, then to go straight to the examination. So my next step is to reduce the sector width, reduce the depth. And for the 2D examination, I prefer to have my own preset for this. So then I magnify that up. And I select on the grey maps, I select quite a contrasty map, and then I like to have ICE for examining the heart. I then come back to the main, and then I come back up to the 4 chambers. I split my image showing the stomach, which I've already established is on the left side of my sweep, and then I come up to showing the heart, and I briefly look at the heart, just to look at I eyeball this, but you can draw a line through the interventricular septum, and then draw a line through the spine and calculate your angles, but that's at about 45. So that's a normal cardiac axis. I then go back to single screen, and I do a sweep as I go up through the left ventricular outflow tract, up to the pulmonary artery, and up to the transverse aorta. And it's hard to see these in 2D to distinguish them without the use of color, and I'll show you how it is much easier with color. You can then see, once you magnify this image, a little bit more dynamic range, because what you want to see is the normal movements of the atrioventricular valves. So if we can cine loop, just go through that. Just press the cine and run through it. You see the movement of the atrioventricular valves in 2 cardiac cycles, and they appear normal. And you can also see the atrium primum. You can also just begin to see the pulmonary veins. But these are much more easily seen with color Doppler examination, particularly slow flow. And then down to up to the 3-vessel tracheal view onto the clavicles on each side. See both clavicles, and down to the transverse aorta, 4 chamber, and then down onto the fetal stomach. But really the examination for me begins once I start going to using color Doppler. So I'm going to, for this, I'm going to go to the preset of cardiac, and then just go straight to HD zoom. The cardiac is preset is mainly because of the color. It's ideal for all the color settings. So if we then go from this point to select standard color Doppler, we can split an image showing the 4-chamber outflow tract. But first I'm going to increase my PRF up to 30 centimeters. So I start usually around 25. I'm going to pull back on the color gain because there's too much color filling those ventricles, and maybe acoustic output I'll reduce to 86, keeping an eye on the thermal mechanical indices in the top right hand corner. Once I've got the cardiac inflow into both ventricles, and I see the interventricular septum, I then go on a sweep to the 3-vessel tracheal view. And as I do so, then I compare the inflow to the outflow. And there's my 3-vessel tracheal view, showing my transverse aorta adjacent to the trachea, and SVC, which I won't show color, with a PRF of 30 centimeters, so I'll need to reduce it to show that. And I can see the arterial duct and main pulmonary artery. And I can unfreeze this and then go back from that to the 4-chamber. And that's, I think, a good exercise to get into, showing a split image showing these two and saving that to your archive. You can then go to full screen and then just repeat that in real time, showing 4-chamber, and up to the 3-vessel tracheal view. You will find, though, if you move to a power Doppler setting, you may, and again, it varies tremendously from patient to patient. If this is at 18 centimeters of PRF, and I'm going to go up to, similarly, 30 centimeters on 30 weeks and 1 day, you can find out whether 24 or 30 suits best. And my controls are constantly on the acoustic output, the color gain, and the PRF. They're the 3 controls that I use in looking at color. So again, when looking at the heart to get inflow, I have the apex up at 1 o'clock. So 1 o'clock or 12 o'clock. Split the image. Now always narrow the box down, so it's just examining the heart. And then I'm going to increase the color gain. And if that doesn't work for me, just reduce my PRF. I just want to get a little bit more ventricular fill, and then moving to my 3-vessel tracheal view. Now you'll see the difference between this color is that I'm also seeing the superior vena cava in this, and I'm also seeing the azygos vein coming up here to drain into the superior vena cava. So this here is your transverse aortic arch, and then beside it, this vessel here is your superior vena cava. And if you want to reduce your PRF and increase your gain, you can actually take it down to 13 centimeters. You can show a little bit more of your azygos vein coming in. So there's your azygos vein joining into the SVC. But you'll see as soon as you do that, you get aliasing in the great vessels. So I'm going to put my PRF back up just to show my 3-vessel tracheal view. And similarly, once I've got that in view, showing the V sign, then I go back to showing the cardiac inflow. And you can do that, go back onto full screen. But I think split screen is a good idea just from a learning point of view. Once you do that, you can rotate the transducer very slightly, and you can see the left ventricular airflow tract. And in this view here, you're seeing the continuity of the anterior wall with the interventricular septum. So there's no aortic override, but you're not getting the color fill. And that's frequently the case with power Doppler in the first trimester, which takes now to the slow flow technologies. Now, slow flow, the first thing I do is I select a map of 4. I put the background I leave as on, and then radiant flow I put to max. And you'll see as soon as I do that, that I get my left ventricular airflow tract. So there's the aorta coming out of the left ventricle. You can see the swan neck-like curvature of the aorta. And then you can sweep up to your 3-vessel tracheal view. And you can do that as a split image. So if you show your 3-vessel tracheal view, again, controls are gain. And more so in slow flow, you need to control your power. So I'm down to 78 for power. And then you can demonstrate your 3-vessel tracheal view. You see the baby becoming quite active now, and it does do that with slow flow. And then here you can see the curvature of the left ventricular airflow tract. You can see the aorta, and then you sweep from that to the 3-vessel tracheal view. So on a single use of the cine loop, which is very important, you can change your section from the 3-vessel tracheal to the left ventricular airflow tract, and then down to the 4-chamber. So I'll just update that. Now, when you go to the 4-chamber, you may have to pull back on your power. And I'll just show you this because this is worth knowing about, is you can choose, first of all, go to a split screen. So you're demonstrating both your 4-chamber and you're in 2D and color. But now what I'm going to do is I'm going to select background, and I'm going to put the background off. So what I've got here is on my right side is just the color information, because I have on the left-hand side the 2D information. And this is a nice exercise, getting used to looking at the 4 chambers, the pulmonary veins entering into the left atrium, which you clearly can't see on the left side, but here the pulmonary veins entering here into the left atrium. You can also see the aorta coming out of the left ventricle, that curvature. And you get more definition of the fill of the ventricles, and not infrequently you can see tiny little ventricular septal defects, particularly at 10 weeks of gestation with this color flow technology. It also shows nicely the sort of the 3-dimensional perspective of the fill of the ventricles, and this here is the interventricular septum. And then back up to the 3-vessel tracheal view, it shows nicely coming in here, the azygos vein, draining here into the IVC. And then as you go up to the neck vessel, you can see the subclavians. So if I just move the box down, you can see the subclavian artery and vein on each side going out to the right and left arm. And when you're looking at the subclavian artery and vein on each side, I'm just going to put up a little bit more my gain. You can also see your internal thoracic vessels as well. So I'll just freeze on that. So that shows you the coming across the subclavian artery and vein on each side, but it's also showing you the internal mammary artery and vein and the left brachiocephalic vein. And you can see there's no way you'd appreciate that by looking at the image on the left-hand side. And then you can see the individual tiny branches here coming in. There are 3 individual branches that come off the subclavian artery. Now, if you want to see those in a little bit more detail, you will need to increase the gain to see the branches coming off the subclavian artery. And there they are coming in. I've got, on this right side, I've got two of the branches just coming in. 2 are posterior and then 1 anterior coming in here, here, and the anterior branch I haven't shown that well. But it just shows you the power. Remember, only 13 weeks of gestation looking at this slow flow technology. And then just come out of that, the other application for this is if you come down to the four-chamber view of heart and you rotate, you can see in this situation we have a nuchal translucency, which is the part of the reason for doing a dedicated cardiac scan. And you can see that the nuchal translucency is just on the upper limits. So if I come across on this, and I'll show you the power of looking at the ductus venosus. So as you look at this here on color Doppler, you look for the ductus venosus. It's quite hard to find, but if you can then go to power Doppler, you'll find it's much easier using power with radiant flow. And you magnify the image, pull back on the 2D gain, reduce the PRF, because it's a tiny vessel, the ductus venosus. And at a PRF of 17 centimeters, I'm now seeing the ductus venosus beginning to appear. You can place your pulse Doppler gate over it. And that's a typical ductus venosus waveform. Then you can click on auto trace, and that gives you your just let me press ductus venosus, that gives you your PVIV of 0.98, which is plumb normal for 13 weeks. And that's important in the setting of seeing an increased nuchal looking at the heart. So if I come out of pulse Doppler, again, the importance is just keeping the gate just small. And then you put on slow flow technology, it's even easier to see. Now, once you do this, you can split your image. You come across. Well, actually, I'm going to go as a single image. I'm going to take my background off, and I'll come back to that in a sec. One of the vessels I want to show you here is just how much easier it is to see the ductus venosus by using this slow flow technology. Not only can you see the ductus venosus, but you can also see the tiny little vertebral branches coming off the descending aorta. You can also see coming in the superior mesenteric artery coming off the descending aorta. You can see the three neck branches coming off the aorta. You can see the junction of the IVC coming down in to join the ductus venosus and the right hepatic vein, and here you can see the umbilical artery and the point of the cord insertion. So it does give you quite a lot of detail about these tiny vessels. If you want to look at that as a split image, you go to main flow and do as a split image. Just take down your gain. It allows you to look about 2D, and now what I do is go into background and put background on. And that allows you just to work out exactly where you are in 2D as you look at the left screen, and then it just tidies up, in a sense, the vascular imaging that you're getting with the background off. And when I then go to full screen with background off, I can then look at the full circulation. I can just simply magnify that and take out all my grey information, and now look at all these tiny vessels. Once I've got to this point, I just ask the patient to hold her breath. So if you can just stop breathing just for a second. 5, 4, 3, 2, 1. And what I was doing there was sweeping from right to left side. And as you do that, you see all these tiny little vascular branching in these vessels as you sweep to the right and the left of the midline of the descending aorta. And it just shows you the power of what you can see with this technology. And I'll finish up by just coming out of that for a second and looking at the aorta, which is important in the setting of seeing the nuchal that's at the upper limit. So if we take that, actually, let's just measure the nuchal translucency. We got it. So have it perpendicular to the beam, correct magnification, defining the two lines, and then taking a measurement, going to biometry, second trimester, nuchal translucency, and then just take this measurement and see what we've got. Okay, that's coming down as just 2.5 millimeters at 13 weeks. So once I do that, I angle around to get the aorta coming up. So I've got the head coming up at around 11 o'clock, and I can see the arch now on 2D. I'm going to take off slow flow. I'm just going to look with radiant flow, and then I'm going to magnify the image, and then look at the descending aorta. Now my PRF is around 23 centimeters. I'm going to invert my image. So I'm going to have just red at the top. You can see my superior mesenteric artery, but this is a nice view of showing the curvature of the aorta. And if you want to bring in the neck vessels on power Doppler, then you bring down your PRF, and I'm down at 9 centimeters, and you may or may not be able to demonstrate them. I will need to pull back a little bit of my gain to tidy that image up. I can see one of the neck vessels heading up, and I can also see the azygos vein. So if you can see this vessel coming up to join the SVC here, that's the azygos vein. Now, you will see how much clearer that is if you turn on to slow flow, is that you can see the aorta here, and then go to the right of that, and now you have a full azygos arch. So this here is your azygos arch, and then this here is your aortic arch. So you see how closely positioned they are to each other. Not only are you seeing your aortic arch, you're seeing the nominate of the left common carotid and the left subclavian artery, the three branches coming off the aortic arch. You're also seeing the nice curvature. And then you, as I say, you go to the right of that, and then you see your azygos vein coming up and draining normally into the superior vena cava. So that shows you the power of this technology. I want to, when you're looking for subtle abnormalities such as an azygos continuation of an IVC in the setting of an interrupted IVC as an isolated finding or part of left atrial isomerism, that you can rely on the slow flow technology to demonstrate that to you. You can also just do it as a split screen, so you show the azygos arch here, and then you come back and you show, in this one here, you show the aortic arch. And you can see the azygos arch a little bit lower, certainly there into the superior vena cava and entering into the right atrium. So just take a picture of that and save it to the hard drive. And that's it really as a cardiac assessment in one go. I think that's probably enough on the timing of things, and I just might stop the examination there.